Welcome to the Deep Dive, the show where we take a stack of information, sift through the noise, and pull out those crucial insights you need to be truly well informed. Today, we're plunging into a world that's incredibly important, yet often nuanced and complex: psychiatric diagnostics and treatment. It's an area where it's, well, easy to get symptoms confused or maybe treatments wrong, but precision can make all the difference. We've got some really fascinating source material in front of us, and our mission is to distill those crucial distinctions for you.
And these aren't just academic distinctions, are they? I mean, understanding the subtle differences between disorders or the, very specific indications for certain treatments
Yeah.
that can profoundly impact patient outcomes. These are the aha moments that don't just transform understanding, but can truly change lives for the better, making a tangible difference in someone's recovery journey.
Absolutely. So, our mission here is clear. We're going to cut through the noise, examine specific scenarios from the source material, pinpoint common pitfalls where confusion can arise, and distill the most important nuggets of knowledge. By the end of this deep dive, you're going to have a much clearer grasp on some truly critical areas of mental health. Let's get right into it, starting with navigating the often tricky waters of medication risks and side effects.
Okay, kicking us off, let's talk about a powerful antipsychotic, clozapine. Now, it's a game changer for many with treatment-resistant schizophrenia, but it comes with a particular risk. Our sources highlight that clozapine is the most epileptogenic antipsychotic, meaning it significantly lowers the seizure threshold in a dose-dependent way.
And this is where it gets really interesting because the scenario often described as a patient with that history of treatment-resistant schizophrenia, maybe multiple hospitalizations, who is on clozapine and suddenly experiences a generalized tonic-clonic seizure. You might instinctively look for other culprits, right? Maybe they're also on an anxiolytic like buspirone.
Right.
But given that patient's history, why is it so vital to immediately zoom in on clozapine as the prime suspect here?
That's a crucial question. The aha moment here is that it's less about the new drug or the obvious drug and more about understanding the unique pharmacology of clozapine itself, especially in the context of a patient for whom it's kind of a last resort. The patient's long-standing treatment-resistant schizophrenia often means they're on a higher dose of clozapine, and that increased dose directly correlates with a higher seizure risk. It's a critical lesson in maybe diagnostic humility. Sometimes the answer isn't what's new, but what's enduring and inherently potent in their treatment regimen.
That makes so much sense, yeah. It's about seeing the whole picture. So we've talked about a medication that can lower the brain's activity threshold to a concerning degree. What about the opposite end of the spectrum? Let's pivot to acute stimulant intoxication, where the system is in overdrive.
Excellent pivot. Yeah. When someone experiences acute stimulant intoxication, think someone studying nonstop, maybe abusing illicit stimulants, or even an Adderall overdose, the sources describe symptoms like profound agitation, insomnia, and a significant sympathetic overactivation. This is your body's fight-or-flight system gone wild.
That's right.
Increased blood pressure, rapid heart rate, and often erratic, unpredictable behavior.
And here's another one of those sort of counterintuitive points, because the first-line treatment here is a benzodiazepine, like lorazepam. Now, for many people, benzodiazepines often raise a flag of caution in psychiatry.
Different.
But in this specific acute context, why are they the go-to over, say, an antipsychotic?
That's a vital distinction. In this situation, benzodiazepines are preferred because they directly calm that central catecholamine excess, basically, the surge of adrenaline-like chemicals causing the severe psychomotor agitation and the autonomic hyperactivity. They're hitting the core biological imbalance quickly and effectively to bring the system back from the brink. Antipsychotics, while they might sedate, don't as directly address the underlying neurochemical storm in the same way and can even, well, worsen some aspects if not chosen carefully.
It's truly about targeting the root cause, isn't it?
Okay.
From overstimulation, let's move to something equally critical but perhaps less obvious: anticholinergic toxicity. This is where medications can have an unintended, even dangerous drying and stimulating effect on the body.
Absolutely. Imagine a patient who becomes acutely delirious. Perhaps they're already on clozapine and then prescribed another medication with strong anticholinergic properties, like doxepin, a tricyclic antidepressant. They present with hallucinations, fever, a fast heart rate, tachycardia, dilated pupils, and dry mucous membranes. What's fascinating here is how to distinguish this from something as serious as neuroleptic malignant syndrome, or NMS, which is a rare but life-threatening reaction to antipsychotics.
Right, and that differentiation is key because the treatments are so different and time is of the essence. What are the telltale signs that point you away from NMS and squarely towards anticholinergic toxicity in this scenario?
Well, the absence of what we call lead pipe rigidity, that extreme muscle stiffness and significantly elevated CK levels, which point to muscle breakdown, those are the big clues against NMS. Instead, those signs of extreme dryness, dry mouth, dry eyes, difficulty urinating along with the tachycardia and dilated pupils strongly point to anticholinergic toxicity. Both clozapine and doxepin have strong antimuscarinic effects, which means they block certain receptors that regulate these bodily functions. It's like putting a brake on the body's rest and digest system.
And this is where the precision really matters because the very next step is crucial. You need to get an electrocardiogram, an ECG. Why is an ECG so critical in this specific context?
It's critical because of the doxepin, the tricyclic. Tricyclic antidepressants, even in therapeutic doses, but especially in overdoses, or when combined with other anticholinergic agents, can cause QRS prolongation on an ECG. This is a life-threatening cardiac complication that can lead to fatal arrhythmias. So it's not just about identifying the problem, but knowing the immediate critical action to prevent a potentially fatal outcome. That's your aha here.
Yeah.
The ECG isn't just routine, it's a life-saving diagnostic.
Okay, wow. Let's shift gears a bit. Still talking medications, but specifically side effects, the extrapyramidal symptoms or EPS from antipsychotics. These can be really distressing. What about acute dystonia?
Right, acute dystonia. This is a sudden, sustained muscle contraction. It can manifest as something like an oculogeric crisis, eyes rolling up, or torticollis, where the neck twists involuntarily. It usually happens soon after starting an antipsychotic, especially older ones like haloperidol.
And it looks pretty dramatic, I imagine. Can even be mistaken for a seizure sometimes.
Exactly, because of the rigidity. But it's an EPS, caused by an imbalance between dopamine and acetylcholine in the brain. The treatment is aimed at restoring that balance, usually with anticholinergic meds like benztropine or sometimes diphenhydramine.
Okay, so benztropine or diphenhydramine for acute dystonia. What about akathisia? That's another common one, right? The restlessness.
Yes, akathisia is that awful inner feeling of restlessness, like you absolutely cannot sit still. Patients pace, shift their weight constantly. It's subjectively very unpleasant.
And the management is different here.
It is. The first step is usually to try and decrease the dose of the antipsychotic causing it, if possible. And then the first line add-on treatment is typically propranolol, a beta blocker. It's quite effective for the restlessness.
Propranolol, first line. What about benzodiazepines like lorazepam? Are they used?
They can be, but they're generally considered second line for akathisia, mainly because of the risk of dependence. You might use them if propranolol is contraindicated, maybe due to asthma or low blood pressure, or for really severe short-term distress while you're adjusting other meds.
Got it. And briefly, there are other EPS too, like Parkinsonism and tardive dyskinesia.
Right. Parkinsonism looks like Parkinson's disease tremor, rigidity, slow movement. Treated often with benztropine or amantadine, though you have to be careful with benztropine in the elderly due to cognitive side effects. And then tardive dyskinesia, or TD, is the late onset one. Involuntary movements, often around the mouth, lip smacking, grimacing, sometimes coriform movements of the limbs or trunk. TD is treated differently with VMAT2 inhibitors like valbenazine or deuterbenzine. And importantly, increasing the antipsychotic dose can actually worsen TD long-term, even if it masks it temporarily.
Okay, really important distinctions there. Let's talk about another medication-related issue. Bipropium. It's a common antidepressant, often helpful for folks struggling with weight gain on other meds, but there's a major contraindication, isn't there? Especially related to eating disorders.
Absolutely. This is a critical point. Bupropion is strictly contraindicated in patients with bulimia nervosa or anorexia nervosa, particularly the purging subtypes.
Why is that?
Because bupropion significantly lowers the seizure threshold. And patients with eating disorders, especially those who purge, often have electrolyte imbalances like hypokalemia, hypochloremia from vomiting, which also lower the seizure threshold. So combining bupropion with an active eating disorder creates a dangerously high risk of seizures. It's a hard contraindication, even if the patient also has depression.
That's a really crucial safety point. Okay, one more medication toxicity scenario, this time involving over-the-counter or OTC medications, especially in kids.
Yes, this comes up surprisingly often. Imagine a child who develops hallucinations or significant behavioral changes after taking, say, common cold or allergy medications. Many OTC decongestants or antihistamines contain ingredients like diphenhydramine or pseudoephedrine.
And those can cause problems.
They can. Diphenhydramine has strong anticholinergic effects, similar to what we discussed earlier, which can cause confusion, agitation, even hallucinations, especially in young children or the elderly. And pseudoephedrine is a sympathomimetic, stimulating the system, which can also cause agitation or restlessness.
So it might look like something else, like an infection.
Right. You might think of encephalitis if there are behavioral changes and maybe a mild fever. But the key here is often the lack of signs of severe infection and the clear link to recently taking these OTC meds. It's anticholinergic or sympathomimetic toxicity.
Good reminder to always ask about OTC meds. Okay, let's shift focus now to untangling complex diagnoses, particularly in children and adolescents. This can be so challenging. Let's start with a common area of confusion: ADHD versus disruptive mood dysregulation disorder, or DMDD. How do you distinguish between a child who is just constantly in motion or distracted and one who has a more profound mood dysregulation?
This is a vital distinction because while both can present with challenges in school or at home, their core nature is very different. Our sources describe ADHD in a child as primarily involving, well, impulsivity, distractibility, disorganization. They might blurt out answers, have trouble following instructions, need lots of redirection. These behaviors largely stem from impaired executive function issues with planning, attention, and impulse control.
And here's where the confusion often comes in. These ADHD symptoms can sometimes look like defiance or maybe poor social behavior, leading to frustration for everyone involved.
Exactly.
But DMDD is sharply contrasted by something else entirely, isn't it?
Yes, absolutely. DMDD, or disruptive mood dysregulation disorder, is defined by severe chronic irritability. It's a baseline irritable mood punctuated by frequent, often explosive temper outbursts. And these outbursts are way out of proportion to the situation, happening multiple times a week. The key differentiator is that with DMDD, the core issue isn't inattention or hyperactivity, it's that persistent, pervasive irritability and difficulty regulating emotions.
Right.
It's about the fundamental nature of the problem. One is often an executive function challenge, the other is an emotional dysregulation challenge.
That helps clarify it beautifully. Okay, another tricky area in child development: distinguishing normal developmental variations from something like autism spectrum disorder, ASD. Sometimes parents worry about, say, a 4-year-old who insists on routines or is a picky eater. How do you know when it's typical development versus a sign of ASD?
That's a great question. It's normal for young children like a 4-year-old to show preferences for routine, have specific food likes and dislikes, and engage in imaginative play. These are often signs of growing autonomy and cognitive development. The crucial thing to look for, which argues against autism, is strong social reciprocity. Does the child make good eye contact? Do they smile back? Do they share their enjoyment with others? Do they engage in age-appropriate interactive play?
So the presence of those social skills is key.
Exactly. Autism involves intrinsic pervasive deficits in social communication and interaction. So you'd see persistent difficulties with initiating and maintaining social relationships, poor use of nonverbal communication like eye contact and gestures, and often restricted repetitive patterns of behavior or interests. Normal preference for routine doesn't usually come with those core social communication deficits.
Okay, that makes sense. Let's talk about tics. Tic disorders. How do you differentiate between the different types, like Tourette's versus others?
Right. Tourettic disorders involve sudden, rapid, recurrent, non-rhythmic motor movements or vocalizations. The main distinction lies in the types of tics and the duration. Tourette syndrome requires both multiple motor tics and at least one vocal tic, not necessarily concurrently, lasting for more than a year, with onset before age 18.
Both motor and vocal for over a year. Okay.
Yep. Then you have persistent motor or vocal tic disorder. This involves only motor tics or only vocal tics, but not both, again lasting more than a year.
Just one type, but persistent.
Correct. And finally, provisional tic disorder involves single or multiple motor and/or vocal tics, but they've been present for less than 1 year.
So duration is key for provisional. Got it. And how do these differ from things that might look similar, like maybe Sydenham chorea or absence seizures?
Good question. Sydenham chorea, which can follow a strep infection, involves more random, flowing, dance-like movements, chorea, rather than the stereotyped, repetitive nature of tics. And absence seizures are episodes of sudden staring, behavioral arrest, lasting seconds, often with eyelid fluttering. But crucially, there's no postictal confusion, and the EEG shows a classic 3 Hz spike and wave pattern. Tics are typically brief movements or sounds, and the person is aware during them.
Okay, clear differences when you look closely. Now let's talk about another crucial area in child development, reactive attachment disorder, or RAD. This is a condition often tied to early trauma, but it needs to be very carefully distinguished from other conditions that might look similar on the surface, maybe like autism again.
This is an incredibly important area, and one where misdiagnosis can have significant long-term consequences. Reactive attachment disorder, or RAD, typically occurs in children, usually under 5, who've experienced a pattern of insufficient care, maybe severe abuse, neglect, or frequent changes in caregivers, like in institutional settings. These conditions prevent them from forming healthy, secure attachments.
And what does RAD look like behaviorally?
These children often show marked emotional withdrawal. They rarely seek comfort from caregivers when distressed, and they respond minimally when comfort is offered. They also show limited positive affect and may have episodes of unexplained irritability, sadness, or fearfulness, even during non-threatening interactions with caregivers.
So the core feature is really a lack of attachment behaviors, a failure to connect in that expected way.
Exactly. That's the key aha here. In RD, the child often have the capacity for social interaction, but they consistently fail to initiate or respond in developmentally appropriate ways, especially regarding seeking or accepting comfort. It's a deficit in the attachment system.
How does that differ then from autism spectrum disorder, where social interaction is also affected?
It's different because in autism, the core deficit is in social communication and reciprocal interaction itself. Difficulty understanding social cues, poor eye contact, restricted interest, repetitive behaviors. A child with RAD might make eye contact, but they won't use that connection to seek comfort or share emotion in the same way.
And how about differentiating RAD from other trauma-related conditions, or even things like disinhibited social engagement disorder, DSED?
Good point. DCD also stems from similar insufficient care backgrounds, but the presentation is the opposite of RAD. Children with DSCD are overly familiar and interactive with unfamiliar adults, lacking appropriate social boundaries. And while RAD involves trauma, it's distinct from PTSD, which typically involves re-experiencing the trauma, avoidance, negative mood cognitions, and hyperarousal, but not necessarily that fundamental lack of attachment behavior seen in RAD. Adjustment disorder or depression might involve sadness or withdrawal, but again, lack that specific pattern of absent attachment. You have to look at the specific pattern of social relating and comfort seeking.
Really requires careful observation of those relational dynamics. Okay, let's touch briefly on brief psychotic disorder, especially when it follows trauma.
Right? Brief psychotic disorder involves the sudden onset of psychotic symptoms like delusions, hallucinations, disorganized speech, or grossly disorganized behavior that lasts for at least a day but less than 1 month, with eventual full return to premorbid functioning.
And the trauma link.
It often occurs in response to a significant stressor or trauma, like the sudden death of a loved one. The key is the presence of frank psychosis, a break from reality directly following the stressor.
How would you distinguish that from acute stress disorder, which also follows trauma?
That's a critical distinction. Acute stress disorder, ASD, also follows trauma and involves intrusive memories, nightmares, avoidance, negative mood, and hyperarousal, similar to PTSD but lasting from 3 days to 1 month. However, ASD does not typically involve frank psychotic symptoms like delusions or hallucinations. The reality testing is generally intact, even if the person is highly distressed. Brief psychotic disorder involves that clear break with reality.
Got it. Psychosis is the key differentiator there. It's all about precision, isn't it? From children, let's move into disentangling some overlapping psychiatric symptoms in adults, particularly the subtle but important differences within anxiety disorders. Someone might say, I'm just anxious, but there are very distinct types of anxiety with different triggers and presentations.
Absolutely, and getting this right is foundational to effective treatment. Let's compare, say, social anxiety disorder, panic disorder, and generalized anxiety disorder. Social anxiety disorder, or SAD, is characterized by a specific, marked fear or anxiety about one or more social situations where the individual might be exposed to possible scrutiny by others. Think public speaking, meeting new people, eating in public. The anxiety is triggered by fears of being negatively evaluated, judged, embarrassed, humiliated, and these situations almost always provoke fear and are often avoided. It occurs predictably in those specific contexts.
Okay, so situation-specific fear of judgment. What stands out here is how different that is from panic disorder, which often feels like it comes out of nowhere.
Exactly. Panic disorder involves recurrent, unexpected panic attacks. These are abrupt surges of intense fear or discomfort that peak within minutes, accompanied by physical symptoms like palpitations, sweating, trembling, shortness of breath, chest pain, dizziness, chills or heat sensations, maybe feelings of unreality or fear of dying. The hallmark here is that at least some attacks are spontaneous, out of the blue, not solely tied to a specific feared situation, although they can sometimes become situationally triggered over time. And importantly, there's persistent concern or worry about having additional attacks or their consequences.
Unexpected attacks plus worry about more attacks.
Okay, and how does generalized anxiety disorder fit in? Generalized anxiety disorder, or GAD, is different again. It's characterized by excessive anxiety and worry occurring more days than not for at least 6 months about a number of different events or activities like work, school performance, health, finances. The worry is difficult to control and associated with symptoms like restlessness, fatigue, difficulty concentrating, irritability, muscle tension, and sleep disturbance. It's more of a pervasive, chronic, free-floating worry, not tied to specific situations like SAD or sudden attacks like panic disorder.
So the crucial differentiator across these is often the trigger or the pattern of the anxiety. Is it predictable to certain situations? Is it entirely unexpected? Or is it a pervasive, generalized worry that's your diagnostic superpower?
Precisely. And you can contrast these with, say, a specific phobia, fear of a specific object or situation like spiders or heights, or even somatic symptom disorder where the anxiety is focused on physical symptoms.
Right. Okay, let's talk about obsessive compulsive disorder, or OCD, and how its presentation can sometimes maybe be confused with psychosis, especially if the obsessions are bizarre or violent.
This is a really vital distinction because treatment pathways are entirely different. With obsessive compulsive disorder, you have obsessions recurrent, persistent, intrusive, unwanted thoughts, urges, or images that cause marked anxiety or distress. These might be fears of contamination, doubts, needing things in a specific order, or even aggressive or taboo thoughts, like intrusive violent imagery toward a loved one. And then you have compulsions, repetitive behaviors, or mental acts. The person feels driven to perform in response to an obsession or according to rigid rules aimed at preventing or reducing anxiety or preventing some dreaded event, though they're often not realistically connected.
And the key here, which really sets it apart from a psychotic disorder, is something called insight, isn't it? The person's awareness about these thoughts.
Precisely. The vast majority of people with OCD have good or fair insight. They recognize that these obsessions are products of their own mind, that they are excessive or unreasonable, even if they can't control them. The thoughts are ego-dystonic. They conflict with the person's self-concept. They feel alien and unwanted. That preserved insight is the critical differentiator from psychosis, where a person might believe intrusive thoughts are real external messages, delusions, or commands they must follow, and they lack that sense of the thought being irrational or just from their own mind.
So they know the thought is crazy but can't stop it, versus believing the thought is real.
Exactly. This is why the first-line pharmacologic treatment for OCD is a selective serotonin reuptake inhibitor, an SSRI, often at higher doses than used for depression, perhaps augmented later. Antipsychotics are generally not first-line, unless maybe there's very poor insight or comorbid enteric disorder. The patient's insight truly guides the treatment.
What a powerful distinction. Okay, let's move to mood patterns. How do you differentiate premenstrual dysphoric disorder, PMDD, from something like cyclothymic disorder? Both involve mood instability.
Good comparison. The key difference is the timing and pattern. Premenstrual dysphoric disorder, PMDD, involves mood symptoms like marked mood swings, irritability, depressed mood, anxiety, plus physical symptoms like bloating or breast tenderness that consistently occur in the final week before the onset of menses. These symptoms start to improve within a few days after menstruation begins and become minimal or absent in the week post-menses. It's tightly linked to the menstrual cycle.
So a clear cyclical pattern tied to periods. How does cyclothymic disorder differ?
Cyclothymic disorder involves chronic mood instability over at least a 2-year period. There are numerous periods with hypomanic symptoms that don't meet full criteria for hypomania, and numerous periods with depressive symptoms that don't meet full criteria for major depression. These ups and downs are present for at least half the time, and the person hasn't been without symptoms for more than 2 months at a time. Crucially, this instability is not tied to the menstrual cycle. It's a more chronic, fluctuating pattern independent of that cycle.
So PMDD is cyclic and menstrual linked, while cyclothymia is chronic and non-cyclic mood fluctuation.
Got it.
How about differentiating somatic symptom disorder from conversion disorder? Both involve physical symptoms without a clear medical cause.
Another important distinction. Somatic symptom disorder involves one or more somatic symptoms that are distressing or result in significant disruption of daily life. But the key feature is excessive thoughts, feelings, or behaviors related to these symptoms. This might be disproportionate and persistent thoughts about the seriousness of the symptoms, persistently high anxiety about health, or excessive time and energy devoted to these symptoms or health concerns. The focus is on the distress and preoccupation with the physical complaints, which are often vague or multiple, like pain or fatigue.
So lots of anxiety and focus on the symptoms themselves, even if they're vague. How is conversion disorder, functional neurological symptom disorder, different?
Conversion disorder involves symptoms of altered voluntary motor or sensory function, like paralysis, blindness, seizures, numbness, abnormal movements, where clinical findings provide evidence of incompatibility between the symptom and recognized neurological or medical conditions. The focus is on a specific neurological symptom that doesn't fit medically. While distress can be present, sometimes you see la belle indifférence, a seeming lack of concern about the symptom, though that's not required for diagnosis. The core is the neurological incompatibility.
So somatic symptom disorder is more about the distress over often vague symptoms, while conversion is about specific incompatible neurological symptoms.
Exactly.
Okay. From the mind's internal struggles and physical manifestations, let's transition to a very specific set of challenges related to substance use, and then to understanding some key personality differences. Let's talk about cannabis intoxication first. What does that typically look like, and how do you distinguish it from other substances?
Cannabis intoxication often presents with euphoria, maybe inappropriate laughter, slowed perception of time, impaired judgment, social withdrawal, and sometimes anxiety or paranoia, especially with higher doses or in naive users. Physically, the most characteristic sign is conjunctival injection, red eyes. Vital signs are usually relatively normal, maybe mild tachycardia.
Okay, red eyes, altered time perception, maybe some anxiety. How does that compare to, say, PCP or LSD?
Very different. PCP intoxication often involves unpredictable, impulsive, and often violent behavior, nystagmus, involuntary eye movements, hypertension, tachycardia, and diminished pain response. Much more agitated and potentially dangerous. LSD and other hallucinogens typically cause visual hallucinations or perceptual distortions, mood lability, but also marked sympathetic activation like tachycardia and hypertension and pupillary dilation. Cannabis doesn't usually cause frank hallucinations like LSD.
And differentiating from stimulants like cocaine or depressants like opioids.
Cocaine intoxication presents with euphoria, agitation, grandiosity, pressured speech, but also significant sympathetic signs. Hypertension, tachycardia, pupillary dilation, mydriasis, possibly chest pain or seizures, much more revved up than cannabis. Opioid intoxication, conversely, causes sedation, respiratory depression, constricted pupils, meiosis, constipation, a picture of CNS depression, opposite to stimulants, and often distinct from the more perceptual changes of cannabis.
Okay, good differentiators there. Now, let's talk about opioid withdrawal. When someone is going through this, what are the classic symptoms, and crucially, what's the appropriate treatment?
Opioid withdrawal is intensely uncomfortable, though usually not life-threatening. The symptoms are often the opposite of intoxication effects. You'll see things like dysphoric mood, nausea or vomiting, muscle aches, lacrimation, tearing or rhinorrhea, runny nose, pupillary dilation, mydriasis, piloerection, goosebumps, sweating, diarrhea, yawning, fever, and insomnia. Intense restlessness and craving are common. It's like a severe flu combined with intense anxiety.
Sounds miserable. And for managing those symptoms, what's the approach?
For managing the autonomic hyperactivity, the sweating, diarrhea, tachycardia, restlessness, the appropriate symptomatic treatment is often clonidine, an alpha-2 adrenergic agonist. It works by reducing the firing of noradrenergic neurons in the locus coeruleus, which become overactive during withdrawal, thereby calming down many of those physical symptoms. Other symptomatic treatments for nausea, pain, etc. can also be used. Buprenorphine or methadone are used for medically supervised withdrawal or maintenance.
Okay, clonidine for the autonomic storm, and this is where a critical timing point comes in regarding another medication, naltrexone. Why is naltrexone absolutely contraindicated during active opioid withdrawal, and when should it be given?
This is paramount for patient safety. Naltrexone is an opioid antagonist. It blocks opioid receptors. If you give it to someone who still has opioids in their system or is in active withdrawal, it will rapidly displace those opioids from the receptors. This causes a sudden and severe worsening of withdrawal symptoms, essentially, throwing the patient into precipitated withdrawal, which can be agonizing and potentially medically dangerous due to fluid loss, etc.
So, absolutely avoid it during withdrawal. When is it safe?
Naltrexone should only be initiated after the patient have been completely opioid-free for a sufficient period To ensure clearance, typically 7 to 10 days for long-acting opioids like methadone, maybe slightly less for shorter-acting ones, often confirmed with a naloxone challenge test or urine drug screen. It's used for relapse prevention in detoxified individuals, not for withdrawal management itself. The timing is everything.
That's an essential clinical pearl, really critical. Now, let's explore a distinction within personality disorders. Antisocial personality disorder, or ASPD, versus narcissistic personality disorder, NPD. Both can involve manipulation or disregard for others, but their underlying drivers and patterns are quite different, aren't they?
They are indeed, though sometimes they can co-occur or have overlapping features, which makes differentiation important.
Hmm.
Antisocial personality disorder, ASPD, involves a pervasive pattern of disregard for and violation of the rights of others, occurring since age 15 years, although the diagnosis isn't made until age 18. You see a history of behavior that would have met criteria for conduct disorder in childhood or adolescence. Things like aggression towards people or animals, destruction of a property, deceitfulness or theft, serious violation of rules. As adults, this manifests as failure to conform to social norms regarding lawful behaviors, deceitfulness, impulsivity, irritability, and aggressiveness. For example, repeated fights, reckless disregard for safety, consistent irresponsibility, for example, work, finances, and a striking lack of remorse for their actions. They often rationalize or blame others.
So, a core feature is that chronic pattern of rule breaking, irresponsibility, and lack of remorse rooted in childhood behaviors. How does that differ from narcissistic personality disorder?
Narcissistic personality disorder, or NPD, is characterized by a pervasive pattern of grandiosity in fantasy or behavior, a profound need for admiration, and a lack of empathy. Key features include an exaggerated sense of self-importance, preoccupation with fantasies of unlimited success or power, belief that they are special and unique, requiring excessive admiration, having a strong sense of entitlement, being interpersonally exploitative, taking advantage of others, lacking empathy, being often envious of others or believing others are envious of them, and showing arrogant, haughty behaviors or attitudes.
Okay, so the focus in MPD is much more on the grandiosity, the need for admiration, the perceived specialness, and the lack of empathy stemming from that self-focus. Exactly. While someone with NPD might manipulate others, it's typically driven by their need to maintain their inflated self-image, gain admiration, or reinforce their sense of entitlement. In ASPD, the manipulation or exploitation is often more instrumental for personal profit, power, or pleasure, sometimes seemingly without any specific gain other than exerting control or causing harm, often tied to that lack of remorse. And critically, NTD doesn't require that history of childhood conduct disorder or the same pattern of persistent unlawful behavior and aggression that defines ASPD. It's really about the motivation and the lifelong pattern of behavior.
That's a great way to put it. The motivation and the pattern, really helpful distinction. Finally, let's discuss some critical treatment and communication strategies that can make all the difference in complex or acute psychiatric situations. What do our sources say is the best approach when a patient expresses suicidal ideation, but is, perhaps understandably, resisting the idea of hospitalization? This is such a tough spot. It really is one of the most delicate and important moments in clinical practice. When a patient shares suicidal thoughts, but is resistant to hospitalization, our sources strongly advocate for a collaborative, validating, and open-ended approach first. The goal is to gently explore their experience, understand their reasons for resistance, and reduce defensiveness, rather than immediately pushing for admission.
So it's not about immediate coercion, but building a bridge first, trying to understand their perspective.
Exactly. You need to build rapport and trust, especially in that moment of crisis. Instead of saying you need to go to the hospital, which might shut them down, you could try something more exploratory and validating.
Can you give an example of how that might sound in practice?
Sure. You might say something like, "It sounds like you weren't expecting this conversation with your roommate would lead to talking about the hospital. That must feel overwhelming. Can you tell me more about what caused your roommate to feel so scared for you?" Or, "I hear that you really don't want to go to the hospital right now. Help me understand what your concerns are about that." Mhm. This kind of non-judgmental, open-ended questioning fosters collaboration, allows the patient to feel heard, and can actually help you gather more information about their immediate risk factors and support system while preserving the therapeutic alliance.
That makes sense. The pitfall here, as you alluded to, is introducing hospitalization too early or in a coercive way, which often just increases resistance and makes them less likely to engage honestly about their safety, right?
Precisely. It's about meeting them where they are emotionally, validating their distress and their autonomy as much as safely possible, and working with them towards safety, rather than imposing it initially. Of course, safety is paramount. An involuntary admission may become necessary, but starting collaboratively is often more effective.
That's an incredible lesson in empathetic communication under pressure. Okay, let's switch gears slightly. For patients with schizophrenia living at home, maybe with frequent relapses despite medication, what intervention can significantly help improve outcomes?
This is where involving the family becomes crucial. For patients with schizophrenia who live with family members, especially if the family environment has high levels of expressed emotion, meaning criticism, hostility, or over-involvement, family therapy or psychoeducation is highly effective. Educating relatives about the illness, teaching them communication skills, problem-solving strategies, how to recognize relapse warning signs, and the importance of medication adherence significantly reduces relapse rates and rehospitalization. It helps create a more supportive, less stressful home environment.
So it's about improving that family dynamic and support system. How does that compare to something like motivational enhancement therapy?
Motivational enhancement therapy, or MET, is more focused on resolving ambivalence about change, often used in substance use disorders or maybe medication adherence for patients with insight. However, many patients with schizophrenia struggle with poor insight into their illness, anosognosia, which makes MET less effective as a primary approach compared to family interventions that address the environmental stressors directly.
Right, you need the insight from MET to really work. Okay, last scenario. For a patient with PTSD who is already benefiting from core treatments like an SSRI and trauma-focused cognitive behavioral therapy, CBT, but is still really struggling with distressing nightmares, what's the recommended next step?
This is a common and debilitating residual symptom for many PTSD patients. Even with good daytime symptom control from SSRIs and therapy, the nightmares can persist. For those patients still experiencing significant distressing nightmares despite these other effective treatments, the next evidence-based step, according to our sources, is often to add prazosin.
Prazosin. What is that and why does it help with nightmares specifically?
Prazosin is an alpha-1 adrenergic antagonist. It blocks certain adrenaline receptors. It's thought to work for PTSD nightmares by reducing noradrenergic hyperactivation during sleep, basically dampening the brain's fight-or-flight response that gets triggered during REM sleep and fuels those terrifying dreams. What's fascinating is that it seems quite specific for reducing the frequency and intensity of PTSD-related nightmares and can significantly improve sleep quality without being a general sedative.
So it's not just knocking them out, but targeting the mechanism of the nightmares themselves. Why is this preferred over other approaches that might seem relevant, like maybe more therapy, like psychodynamic therapy?
It's exactly. While other therapies, including psychodynamic therapy, can be helpful for processing trauma overall, they lack specific, robust evidence for effectively treating these particular nightmares as a primary intervention, especially when the patient is already engaged in gold standard trauma-focused CBT. Prazosin, on the other hand, directly intervenes in the likely neurobiology driving these specific nightmares, offering a clear, evidence-based pharmacological solution when first-line treatments haven't fully resolved this particular persistent symptom. It's about finding the precise tool for the remaining problem.
Wow, what a deep dive. We have just navigated a landscape filled with incredibly critical distinctions. It's amazing. The power of precise knowledge in uncovering the true nature of symptoms and identifying the most effective paths to treatment is just, well, it's immense. I feel like we've had so many aha moments pulling these threads apart, from medication nuances to childhood development and even the art of communication.
It really highlights the importance of careful observation, doesn't it? And critical thinking, and maybe the willingness to look beyond those initial assumptions. Knowledge is most valuable when it's truly understood and can be applied effectively. And embracing multiple perspectives, like we've done looking through these sources, genuinely enriches that understanding. These deep dives are really about equipping you, the listener, with that kind of precision.
Yeah, absolutely. So as you go about your day, maybe consider this provocative thought. How might applying this deep dive approach, this meticulous attention to detail, this relentless pursuit of differentiation, and this understanding of the why behind what you're seeing, how might that change how you approach complex situations or information in your own life far beyond the realm of clinical diagnostics? Keep exploring, keep questioning, and we'll see you on the next deep dive.